Good day. My name is Megan Haupt. I'm the Chief of Staff for the National Association of State Mental Health Program Directors. I welcome you to Season 5, Episode 225 of the 988 Crisis Jam. Today we're talking about A Day in the Life of Crisis Care Part 3, A Safe Place for Help. Really thrilled that we'll have Dr. Scott Zeller, Charlotte Claiborne, as well as Heather Honaker. So that will be further into the jam, but I just want to set that stage. Just really thrilled to have everybody on. Okay, so just some housekeeping pieces, some reminders. If you haven't joined the jam before, and even if you have, just a reminder that to stay on mute. So unless you're a presenter and you're presenting, you can select speaker view instead of gallery so that you can just see the speaker and join in. You can share your thoughts and questions, but do them in the chat. But we love an active chat box, so that's very exciting. When we get to something called the trivia hot seat, please respond in the poll that's provided versus in the chat. So that'll be a fun moment. Also wanted to let you know about the new American Sign Language feature that is located. You can see the arrow here. You have a circle at the bottom of your screen, bottom right, with 3 dots. If you click on that, you'll see the ability to get that new ASL feature. And we encourage that. It's great to even learn something new, even if you don't know ASL, but we're just really thank the interpreters for being on. Right? And what's amazing, we have had 225 episodes since 2020, and there have been 570 unique speakers. Isn't that amazing? So if you've got a topic for us, please let us know. Something that is emerging or something that you really care about, let us know. You'll see in yellow that these are the newest speakers, some from today. But look how small that is. That's how many wonderful experts we have on this in so many variations. It really takes a network, it takes a team, it takes a community to move crisis services forward. And look at that, it's right in front of us. And just want to say that on the website talk.crisisnow.com, you can access episodes, today's episodes. It's being live streamed on YouTube. So we encourage that, but we love when people also participate by Zoom. So there's the registration for the Crisis Jam. We encourage you to do that. It allows you to really actively participate in the chat as well. But some people have a little trouble with Zoom, so we also stream it by YouTube. Great. And there are past episodes there, documentaries. You can see this is from last week, the fireside chat with the grandfather of 988 in crisis care, who's Dr. Richard McKeon. Love Dr. McKeon. Thank you. And these are some of the past episodes. You'll see the different types of formats that we have. We have debates. We have a day in the life, which is the type we have today. We have feature presentations, and you'll see we have fireside chats, kind of more of a deeper interview. So live and on locations, gosh, there are so many, it's grown in such a great way. So we've had several live and on locations as well. So for debates coming up for season 5, we have one coming July 23rd. That's in a couple weeks. One with David, it's with David Covington and Dr. Jessica Pollard. It's on coordinating follow-up care for crisis services. Yeah, there we go. Requires high-tech software solutions. It went so fast. Okay, so David Covington will take the affirmative and Dr. Pollard will take the different perspective. Then coming August 27th, we have a debate. States should prioritize building capacity in the 3 core crisis services. And Paul Galdis will take the affirmative on that. And Dr. Joe Parks from the National Council will be taking a different perspective. It's not that Dr. Parks will be against that, it's just from a different angle. So that's coming August 27th. Season 6, Crisis Jam Unplugged, coming September 17th, 2025. That starts the new season. And we will be moving forward with lots of ideas on that. You'll have to wait and see where we go with that. We're going to the latest crisis news and shifting there. This is a sad story where family blames nurse shortage for son's death in Georgia emergency room. So the family in Georgia had a son that was in crisis. They called 911. They took the son to the ER, and the son had suicidal ideation. And they there was a psych unit had been closed because of staffing shortages. And so there was supposed to be a sight line right to the son. And it appears, at least the family said, that that wasn't done quite the way it should have been. And the son died by suicide there. So they are, take a look at that story and how important it is to really have that workforce and support families. So this is a health hearing about the fiscal year 2026 Department of Health and Human Services budget. This is RFK Jr. talking about the budget as well as the combining, the consolidating of agencies for AHA, otherwise known as the Administration for a Healthy America. Let's take a look at this clip.
Priorities, I want to highlight a few. First, we will consolidate programs to better tackle mental health and addiction. These issues now rival chronic disease in their impact. HHS will aggressively combat the opioid crisis, especially the spread of synthetic drugs like fentanyl. We will empower state, local, and tribal leaders to create effective solutions. Second, we will address nutrition, physical activity, and healthy lifestyles. The president's budget requests $94 billion in discretionary funds to support these priorities, including the Administration for a Healthy America. Priorities.
Thank you. And I want to bring up Sarah Corcoran, who follows federal legislation and these federal issues. Sarah, if you could come on up and let us know what this might mean.
Thank you, Megan. So just very quickly, for a little bit of context, as part of the budget request process every year for the discretionary budget process and appropriations process, the agencies submit their requests to Congress for agencies, for individual programs. So this appearance by Secretary Kennedy is part of that process for FY26. This was before the House Energy and Commerce Committee, which is a very powerful committee on the authorizing side, meaning that they make the laws instead of setting the funding. On the House side, as part of those comments, it seemed to point to the proposal from HHS to consolidate not only SAMHSA within and other agencies within the new proposed Administration for Healthy America, but also later on in the hearing as well, Secretary Kennedy pointed to their proposal to combine the various block grants that are in SAMHSA right now. That includes mental health block grant, the substance abuse and treatment prevention block grant, as well as the state opioid response block grants. All of that to say, we have not seen reaction yet from the appropriations committees on the House and Senate side. We expect to see more from the House side towards the end of this month when they have the subcommittee and full committee markups for the FY26 bill. And then at some point in the future, we will, it remains to be seen when at this point, but we will see from the Senate side their similar response to this proposal. So more to come from that. We'll keep you updated in the federal updates when we are on the schedule with Emily from AFSP and myself. But that's a little bit of context around these comments in the opening statement at the end of June. Thanks, Megan.
Sarah, thank you so much. And thank you for your work in following and helping us understand it a little better. So we're going to do the Crisis Jam Showdown. This is our wonderful trivia question for the audience. So let's go. SAMHSA's concept of, quote, a safe place for help, unquote, emphasizes trauma-informed, person-centered environments. Which of the following practices is least aligned with this principle? So take a look at A, co-locating crisis services with law enforcement, B, including peers, C, offering 24/7 access without barriers, or D, designing settings that are welcoming and trauma-informed. So again, which is least aligned with the principle of trauma-informed, person-centered environments? So go ahead and put your answer in the poll. And let's take a look what the audience has said so far. Co-locating crisis services with law enforcement. 94% of you said that. Are we right? Are we right? Yes, we are. This is an informed group. So while collaboration with law enforcement can be important, co-location may undermine the goal of creating a space free from fear of or coercion, core to the safe place for help principle. SAMHSA prioritizes non-law enforcement centered access points that are calming and person centered. So yeah, I love the comment. Wow, slam that showdown. Exactly. So great. And that means you understand that peers foster trust and reduce stigma. It means 24/7 care, designing settings that feel welcoming and trauma informed. All things are helpful. All right, we are now going to move to a day in the life of crisis care part 3, a safe place for help. I am going to turn this over to Joy Brunson in I'm sorry, Joy. Okay, help me. And Subuga.
Nsubuga, yes.
All
Perfect.
right, there we go. Thank you.
Thank you. Hi, everyone. I'm Joy Brunson-Nsubuga, and I'm excited to be moderating this panel, Day in the Life of Crisis Care, a Safe Place for Help. Of course, the Safe Place for Help is a part of the National Guidelines for Behavioral Health Coordinated System of Care, and we have 3 excellent presenters today that will talk about their experience, their agencies as a part of that safe place for help. We have Dr. Scott Zeller, Charlotte Claiborne, and Heather Honaker. And we are going to jump right in if that's okay. And we're going to start and let each of them introduce themselves in that order, and also talk about their service models and how their models are a safe and supportive place to be. We'll start with Dr. Zeller.
Thank you so much, and great to see everybody today. My name is Scott Zeller. I'm an emergency psychiatrist. I've been working in emergency psychiatry for close to 40 years now. I'm currently vice president at the multi-state, multi-specialty medical group Vituity. I've been really focusing on the emergency level of care for many, many years, as I mentioned. And as much as we know that it has its shortcomings, in most places around the country, people still are going to go to emergency departments in hospitals when they have a mental health crisis. And we all know that, most ERs are really not well set up for these individuals. Yet we've seen their numbers completely growing over the last 10, 20 years. And now about 1 in every patient who are in ERs across the nation are there for a behavioral health emergency. So it's, one of the most common things that are seen in ERs. And you'd think maybe they'd be paying a bit more attention to it. And on top of that, the federal EMTALA laws say that psychiatric emergencies are emergency medical conditions, just like heart attacks. But for some reason, behavioral health emergencies tend to be the only emergency medical conditions in hospital ERs that their default approach is find them an inpatient bed. And so usually these interventions are not much more than a doc seeing them saying, well, they need a psychiatric hospital. and they put them on a stretcher in a hallway, and they say, well, wait, there should be a bed coming up sometime soon, but maybe that's not going to be for hours or even days. That's what's known as boarding. I don't think I need to explain that to anybody who's on the call, but it's really different than the way that ER docs treat any other condition. If you came in with an asthma attack, they wouldn't say, hey, we're going to find you an asthma hospital. They'd start treatment right away. And the vast majority of people with an asthma attack would get better and be able to go home. We know that the same thing is actually true for psychiatric emergencies in ERs if we actually consider starting treatment right away, the same as we would for the asthma attack. But even if we were able to start treatment right away, we all agree that the ER environment's not really conducive to healing for behavioral health emergencies. It can be claustrophobic, scary. There's a lot of uniformed personnel and people running around, and it's hard to get anyone's attention. You're usually in a small little space with a sitter or security guard. So it would be better if we could find something that was not like that. But even when we look at the overall system, there's wonderful, wonderful community programs available, but there's going to be times that people still are going to go to ERs. And I think the best example of that is if you take an overdose in a suicide attempt, you're going to need to go to the ER rather than to a crisis center so that they can work on that overdose and save your life. Also, we see a lot of other kind of situations where maybe they're just too acute for what's available in the community. Somebody who's actively violent and combative or super intoxicated or withdrawal has other medical problems. So instead of thinking that everybody should go somewhere else, there's going to be times people are still going to go to the ERs. And instead of just saying, well, ERs are terrible, what if we made ERs better? What if we actually focused on creating a therapeutic environment featuring immediate psychiatric evaluation and treatment with a goal of getting people stable and discharged to the least restrictive environment to getting them back to the community? And that's the philosophy behind what's called empath. Empath is an acronym. It stands for Emergency Psychiatric Assessment, Treatment, and Healing. It's not a brand name. I know it sounds catchy, but it's actually just a generic medical acronym that's well known in the literature, just like you would say ICU for an intensive care unit. Empath is a part of the hospital for emergency psychiatric assessment, treatment, and healing. Empath units are usually located nearby or even right next to ERs, sometimes even within ERs. And in good scenarios, patients can, if they came into the ER, they can be quickly moved there from the ER right into the empath unit. Just like if somebody came into the ER and said, I think I'm pregnant and about to have a baby, they would say, let's get you to labor and delivery. Same thing with a crisis, they can move you to the empath unit. Many empath units also can take people directly from the field. They don't even have to go into the ER, but they're hospital based. And as you can see in the photo behind me, which is an empath unit in Minneapolis, which is right next door to additional hospital ER, it's open. People are free to move about. They never feel they need to ask anyone for anything. They can serve themselves snacks, beverages, linens. There's recreational activities. They can pace, they can do anything they want. They pick their own recliner. They can even do yoga and stretches if they wish. They can get a mat. Some empath units even have outdoor healing gardens where people can go and relax. And the whole site is really trauma informed and person centered. And one of the keys is that when somebody gets to an empath unit, people are seen within minutes by a psychiatrist or a psychiatric provider who can prescribe, and a treatment plan is started immediately with no decision on the need for inpatient transfer until the treatment plan has had ample time to work. And people are under gentle line of sight observation at all times, and they can reevaluate and adjust the treatment plan as needed multiple times during the stay, which is usually several hours. And this combination of a therapeutic environment and immediate treatment has had amazing results. And for one great comparison, the same exact population, if they were in the regular hospital ER, 15 to 20% of them would go into restraints. If they're in empath units, only 1 or 2 out of every 1,000 go into restraints. So comparing 150 to 200 in restraints out of 1,000 to 1 or 2 in 1,000. And the other great thing is that we're seeing across the board around 75% or more of high acuity, even involuntary patients are able to be stabilized and discharged home in just a matter of hours. Patients that in other systems would still be waiting to go to an inpatient bed during that same amount of time. And there's other amazing metrics. 25 to 50% reduction in 30-day return to the hospital compared to inpatient discharges. They're also 60% more likely to show up for their first outpatient follow-up after empath than an inpatient discharge. moving people to empath opens beds
Thank
into
you, Dr.
ER for
Zeller.
non-psych patients, which is, means that even if you're never going to have a psychiatric emergency, you never know anyone that has, you're still going to have an improved life because there's going to be quicker access to the regular ER because we're moving the behavioral health patients to a much better and more prompt environment. And it even means that those who still need inpatient beds after empath, there's going to be many more beds available because we're not just moving them from the ER to inpatient. We're actually, really only moving the people there who truly need that extended care. There's right now about
Thank
50
you,
empath
Dr.
units
Zeller.
available in the US and Canada. We're about going to have 100 in the US by 2027. But one last point I want to make is that empath is a really kind of historically missing link of the crisis continuum where we're involving the hospitals. And it's not intended to replace any community program. It's intended to complement community programs. And for some of those community programs, now I'll turn over to my colleagues.
Thank you. Thank you. We will definitely come back to you to ask some more questions. But right now, we need to move on to Charlotte Claiborne and the Bridge Center for Hope.
Hi, thank you for having me. Good morning, everyone. I'm Charlotte Claiborne, the Executive Director for the Bridge Center for Hope, which is Louisiana's first ever crisis receiving center. We provide mental health, substance use, crisis stabilization services. Just to give a little quick history of kind of how we started was in Baton Rouge, we had what was called a mental health emergency room extension that was part of our charity hospital, ROK Long. And when that hospital was shuttered in 2012, a lot of individuals had nowhere to go. So they started going to the local emergency rooms, or law enforcement brought individuals to parish prison because there was their only two alternatives. Because of that, there were several incidents that happened in parish prisons where people committed suicides, or the emergency rooms were inundated with individuals who had behavioral health crises. So the Bridge Center for Hope, which is a nonprofit, was formed in 2016. And one of our main goals was to try to build on something that would be able to provide services to our communities for individuals who are having a behavioral health crisis, and to act as an alternative to our emergency departments and as a diversion to law enforcement. And so in 2019, we chose Recovery Innovations as our service provider. At the time, we were looking for something more along the lines or akin to the Crisis Now model. And then RI came in with their living room model. So now we have what we consider like a fusion model light at our facility. But we basically provide that gap, and not a pun on the word, but bridge, but we do operate in a sense where we have a bridge where you're not in an emergency room, but we're not an outpatient service provider. We do provide services where we're inpatient, and we also provide services where involuntary and voluntary alike to individuals 18 years and above. And for the sake of time, I'll go ahead and pass it on, Joy, so you can introduce Heather.
Thank you. Thank you, Charlotte. Now on to Heather.
Hi, everyone. I am Heather Honaker. I'm a managing consultant at TBD Solutions, where we provide support for organizations that are looking to develop crisis services, including crisis residential programs, rather than providing those services ourselves. I have the privilege of serving as president of the Crisis Residential Association and co-chair of CrisisCon, the National Crisis Continuum Conference. So crisis residential programs like the one pictured here offer a short-term community-based alternative to hospitalization for individuals experiencing a mental health crisis. The typical length of stay for this program is 7 to 14 days, though that varies across the country. This crisis residential model is grounded in trauma-informed care, recovery principles, and involves peer support. The hallmark, though, of crisis residential programs is the home-like setting. So pictured here is Vista Balboa, a crisis residential program operated by Community Research Foundation in California. Thank you to Dan Mesha, a CRA board member, who shared this photo. But you can see that this program looks like a home in a neighborhood, because that's kind of what it is. Crisis residential programs typically are embedded within the community and don't have any distinguishing features that would tell you that it's anything other than a home where people receive treatment. There is an emphasis in this service on hospitality and in creating an environment where people feel respected and heard. Crisis residential programs support individuals in regaining stability without the use of restraints or without the use of locked doors.
Nice, thank you. And thank you all for introducing your models. We have just a couple more minutes where we're gonna talk more about each of your levels of care. We're gonna go backwards this time and start with Heather. Can we talk a little bit about access? How does individuals access your services? That's always one of kind of the top questions. So we can
Yeah,
start with Heather.
sure. So, access to crisis residential programs vary across the country, but typically referrals can come from hospitals, from other crisis providers, mobile teams, outpatient providers, and then in some systems, individuals are allowed to self refer to the programs. Eligibility includes experiencing a current mental health crisis, and these are typically voluntary programs, so that voluntary participation is required. And then there's also an element of medical stability that's involved. But I want to be clear that that doesn't mean that crisis residential programs don't also provide a level of medical support. And oftentimes, we find that these programs will provide that support that maybe hospitals or the inpatient level of care would turn away. So helping folks reach stability in that way as well. In general, crisis residential units really strive to minimize barriers to admission and respond very quickly to referrals in order to prevent unnecessary hospitalization.
Great, thank you, thank you. Charlotte, what about your program? Are there any similarities, any differences to what
There,
Heather
there,
you?
there are some differences. So for the Bridge Center for Hope, we don't have referrals. We are open 24 hours, 7 days a week, 365 days a year. What we wanted to do when we created this program is we wanted to make sure that we removed as many barriers from individuals seeking care as we possibly could. So the same way that you would access an emergency room is the same way that you would access the Bridge Center for Hope. We do partner with all law enforcement in our parish. And so law enforcement has their own separate interests in the back where they can bring individuals. We also partner with our local emergency medical service department so they can bring individuals as well. And then we have a front door entrance where individuals can come in on their own or being supported by a loved one. Because we work closely and we're considered a community asset, we are partially funded by a property tax. So because of that, for individuals who do not have insurance or Medicaid or any type of plan or pay, we will cover that cost. So we try to make sure that if someone needs care, they're able to receive care. Our only criteria or barrier, that, if you want to call it that, is that you have to be 18 years and above to access our services. And because we act as a continuum of care, we serve as a referral to places that Heather would operate, or and if that person acuity level is a little higher than what we can maintain, then we can refer to our local freestanding mental health hospitals or to the hospital itself to get something like a medical clearance or something to that nature and back. And then also hospitals do refer individuals to us if they find themselves inundated with individuals and they can't treat them or see them. So we kind of serve that middle ground where we get people from all over. So as long as they're 18 years and above, we will figure it out.
Nice, nice. Now over to you, Dr. Zeller. Same question, but similarities or differences for how to access the impact model?
Well, kind of like what she was saying, I mean, empath units being part of emergency departments are bound by federal law that every single person who comes within 250 yards of the campus must be seen immediately without regard to ability to pay or their whatever their level of acuity is. So it's about the lowest barrier possible. This is one of the things I think that emergency departments would do even if there wasn't a federal law, but it's just a great thing is that anybody who needs help, let's give them the help they need. We'll worry about who how they can cover the costs later, and really just worry about making sure that somebody is going to be safe and is going to live, and that there's not going to be any issues. So we really think of empath units as a really nice and patient-centric and trauma-informed extension of the emergency department. And hopefully, when we have these programs, we're getting people out of that kind of unpleasant claustrophobic emergency department and moving them right over to empath. And that's the whole idea behind it.
So one of the similarities in this conversation has been the environment and the trauma informed care, and really looking at making sure that individuals, when they need help, when they're in crisis have a space where they can feel comfortable, and then the treatment components can start from there. So I know we had like 3 more questions, and maybe we were a little bit, thinking we could get through all of them, and hopefully we'll be able to come back and do some more conversations about this. But I just want to wrap this up in our last 30 seconds. What would you say is the most important thing that individuals listening in would really need to know about your models? And maybe we can have 30 seconds each before we move back over to Megan. Let's start with Dr. Zeller.
So the one thing I would say is that the nice thing about Empath is that any hospital can open one. They can often utilize underused space in their own hospital and kind of remodel it for an Empath unit right off the ER. And there's no really reason not to, because when we're saying 1 in every 8 of your patients coming in is there for a behavioral health emergency, why not have that specialized space for them that's therapeutic, that is going to really help them get better? It's a trauma-informed, patient-centric space where we know the results are going to be much better, and we don't want to have people stuck in ERs, but rather starting treatment right away, and the data just kind of proves that that's the best situation. And these can be anywhere from rural to busy downtown areas, and we tend to see that it's a scalable model that works wherever you go.
Okay, nice, thank you. And you put a lot of information in the chat so individuals can continue to learn more about the model. It looks like there's a lot of excitement. Let's move over to Charlotte.
One of the things I would like people to know is that the Bridge Center has only been open for 4 years, and during this time, we've served over 12,000 individuals. If we compare ourselves to the local emergency departments within our parish, we are number 2 in it as in terms of psychiatric admissions. So we've made a huge impact to the community. So it was, and I'm really proud to say that, because it was the people who voted to pay for this facility who recognized the need of the individuals in East Baton Rouge Parish, and not only East Baton Rouge Parish, but we do serve the entire state, because we are the only crisis receiving center here. So I just want people to know that even though we are the first, we hope to not be the last in Louisiana. We know that crisis care is not often recognized throughout, but we're hoping that our services and the impact that we've had in our community will be able to spread among the rest of the parishes here, which you guys call counties. I think somebody asked the question if we were a locked facility. The answer to that is yes.
Thank you, Charlotte. And if you can put maybe a link to the website or more information in the chat, and we will go to Heather to close us out for today.
Thank you, Joy. Gosh, there's so much more to know about crisis residential programs, but I want to talk a little bit about their impact. And, crisis residential programs consistently reduce psychiatric hospitalizations and emergency room utilization in the communities that they're present. Individuals that receive those services typically report feeling more hopeful and connected and empowered after their stay. And many also express that the peer support and the respectful environment that they're in helped restore, stabilize them, but also restore their trust in the mental health system. And I think that's a really beautiful thing. For the broader community, crisis residential programs really serve as a critical step in the crisis continuum, and we don't talk about them enough. So I'm really excited that we had the chance to share that today. But they're an important part of the continuum, because they do reduce that pressure on hospitals and on law enforcement while promoting recovery-focused care. And they really help to shift the narrative around mental health crises, showing that healing can happen in supportive, non-institutional settings. So thank you so much for having us on today.
Thank you. And we're going to pass it back over to Megan.
Joy, thank you so much. Thank you, Heather and Charlotte and Dr. Zeller. What incredible models when we think about a safe place for help. It's hard to picture it, like what is that? And, how do you make it safe? And there are just different ways of doing it that fit a community. Just wonderful information. So thank you all. Let's bring up the roundtable participants. Kimberly Nordstrom, Dr. Kimberly Nordstrom, who's the Associate Clinical Professor for the University of Colorado Anschutz Department of Psychiatry. And we also have Ashlyn Crosby, who's a nurse practitioner for Recovery Innovations. Dr. Nordstrom, let's go to you first. What is your response and your experiences?
Sure. I'm hoping that no one saw me on camera while the others were speaking because my head was bobbing and it's just so exciting that we're even having this discussion and we're talking about this. So I've been in the emergency psychiatry field for a couple of decades now. And, you know, just to be a part of and watching others in this evolution has been quite exciting. So, to remind everyone, we started from, if you're having a mental health emergency, please call 911 or go to your nearest emergency room. That's where we've all started, right? And I think Dr. Zeller gave you a sense of what the nearest emergency room looks like. And I've worked in two different types. So when we talk about psych emergency, even in that space, it all looks very different. I worked in one that was psych emergency that was associated with the Department of Psychiatry, and it was closer to trauma informed, but still very sterile and jail-like in terms of the individual rooms and that. And I currently work in an OBS unit in an emergency department where I'm a consultant. So, even in that emergency psych space, there's still a lot of room to grow, room to continue to evolve, and especially looking at that empath model. EDs back in the day were so ill-equipped, right? Not at all trauma informed, and no one even understood what those kind of terms meant. Then, probably 2012, Project Beta came out to give emergency physicians a toolkit in terms of how to more appropriately work with people who are in a crisis, those especially agitated. From there was new government interest in community crisis, right? And so then we started talking about the crisis continuum. Whoa, what is that, right? Before it was all just in the emergency department, and now we're imagining crisis work in the community. And so, so again, it continued to evolve. And then probably about a decade ago, uh, Dr. Zeller coined and published his Alameda model, which then evolved into the empath model. I've been watching this and supporting and doing whatever I can to light the fire under empath, because the key term, and we also heard it with the community crisis partners who spoke today, was the healing piece, right? It wasn't just, the person's in crisis and we do things to them, right? It's we do things with them, and it's all about their longitudinal course and not just a moment in time, even though we come from maybe crisis background. So it's very exciting to me to have watched and been a part of this evolution. We still have a long way to go. I saw in the chat people talking about, well, we need this in all the communities. And it would be great to have both empaths and that full continuum. And where we have that, some communities do, that is golden and should be cherished. But we need to continue to advocate to get this all throughout. And we're going into a season where it's going to be tougher with some of the Medicaid changes and that kind of thing. So we have a lot of hope. We have a lot to, that should speed us on because we've had a lot of great results, but we still have a lot of work to do. So those are my thoughts.
Thank you, Dr. Nordstrom. And by the way, when you were on camera going like this, I did see you do that, but it was encouraging. It like added energy. So I just want you to know that was a good thing.
Thank you. Thank you.
So let's go to Ashlyn Crosby. Ashlyn, what is your response? What do you think?
Thank you so much. My name is Ashlyn Crosby. I work for Recovery Innovations, and I have been for the past 4 years. And so, what do we do day in, day out? So much of what we do, and in the crisis world is providing a bridge, a place that people can come when they don't have another place to go. And I think that so many times we hear from families and from individuals that they are so grateful because they're like, I do not know where I would have gone if this hadn't been here. And that's really the heart of what we do every day, building relationships with guests and providing trauma informed care, medication stabilization, substance abuse treatment, and then referral for outpatient services. We fill in that gap, and the ERs in the area. A lot of times, whenever patients go in there, they get turned around and told to come here, which then we love having them come here, and we're so thankful that they do. And so that's one referral source because we are here now. And then other places that we'll get referrals from are other substance abuse treatment facilities, and then families and individuals that have been here, which is honestly the best thing. Whenever an individual says my family member was here and they told me about it, and I wanted to come in and get help. And so that's what we get to do. So many individuals that we see are without family support, income, and those things can be really challenging in navigating the mental health system without any type of support. And so we are so thankful that we get to serve people day in, day out, 365 days a year.
Fantastic. Thank you, Ashlyn. And Charlotte just noted that you are at the Bridge Center for Hope. So
Yes, ma'am.
thank you so much for all the work you're doing, and you, Charlotte, as well. So thank you both so much for your perspectives. It is an exciting journey, and we certainly hope it continues to expand, and we appreciate your work. Thank you. All right. And we are going to the SAMHSA update. Super thrilled to introduce Dr. Richard McKeon, who is considered the grandfather of 988 and crisis services. Dr. McKeon, please go ahead.
Thank you, Megan. Really appreciate being on the Crisis Jam today. It was a great experience last week, being part of the featured presentation, and glad to be on today to do the SAMHSA update. Main thing that I wanted to make sure people were aware of is that SAMHSA currently has a grant opportunity available for the Suicide Prevention Resource Center. The Suicide Prevention Resource Center, or the SPRC, has been a core part of the nation's suicide prevention infrastructure ever since its start in 2002. And I've been honored to be able to be a part in various roles of the SPRC since going back to 2003. But a couple of things about this notice of funding opportunity. One, it's on a fast time track. It is due July 22nd. So that's only a couple of weeks. We are certainly hoping for a strong response given the crucial nature of the Suicide Prevention Resource Center for the nation's suicide prevention efforts. The amount of the grant is $10.2 million. The main contact person within SAMHSA is Brandon Johnson, but if you don't have his contact information, feel free to contact me, and I will put you in contact with Brandon, who's both chief of the Suicide Prevention Branch, as well as the government project officer for the SPRC. And just as a brief example of some of the amazing activities that the SPRC engages in, which includes providing support to the National Action Alliance, suicide prevention. Just today, the SPRC announced the release of a new online course, Suicide and Intimate Partner Violence, Screening and Safety Planning with Adults. And we in the past we've had meetings around this topics, and there are so many corollaries regarding suicide and intimate partner violence, including the importance of screening, safety planning, the existence of a national hotline, etc. Another example is that last year they had adapted their long-standing counseling on access to lethal means curriculum specifically for crisis hotline workers. So that's just an example of some of the amazing work done by the Suicide Prevention Resource Center. We are glad that it is being, it will be re-awarded. Again, it's a $10.2 million grant program, and it's due July 22nd. So that's the main thing I wanted to emphasize.
Wonderful, Dr. McKeon. Thank you so much. And thank you for your legacy and your work and your continued dedication. We are also thrilled that notice of funding is available and that the SPRC continues. So thank you. Great. I'm now going to turn it over to Allie Lichterman, who's with the Illinois Department of Human Services. Allie, we are thrilled to have you on. This is Allie's first time on the Jam, and we are just super thrilled you're on. Go right ahead.
Good morning, and thank you so much for having me. So she said, my name is Allie Lichterman. I use she, her pronouns, and I am the Crisis Community Programs Administrator for the Illinois Department of Human Services Division of Behavioral Health and Recovery, so overseeing our crisis continuum work, and really excited to be sharing 2 updates. So going to start with an update on our Community Emergency Services and Support Act, which we call CESA. This is the law that regulates how we are expanding alternate response statewide. Do want to give some background. It began with young Black and Brown disability advocates wanting to ensure people experiencing mental health crisis got appropriate care to meet their needs, and they were very influenced by the tragic experience of Stephon Watts, a Calumet City high school student with autism who was tragically killed after calling 911. So in response, and due to all the great pushes from our legislature, CESA directs 911, our PSAPs, to provide callers seeking emergency mental and behavioral health services with mobile mental health services without law enforcement, unless there is ongoing criminal activity, a threat of violence, or assistance needed for involuntary transport. Next slide, please. Thank you. So want to highlight, how is this actually going to look right now? If you call a PSAP 911, and there needs to be dispatch, typically it goes to fire, police, EMS. This adds this other option where if it's mental health call with no risk of violence or weapons present, it's transferred to 988, and they can either de-escalate over the phone, which we know they can do the majority of the time, or if an in-person response is needed, send a mobile crisis team made up of a community engagement specialist, usually a peer and a clinician, and ideally long-term, those teams and our other first responders should all be able to communicate, to call each other for support and backup. Next slide, please. Thank you. So where are we actually at right now? What's the update? We are piloting the full CESA implementation, which is 911 to 988, and then to mobile crisis if needed in 19 pilot sites around the state. We have until July 2027 to get to full implementation. So we have about 175 PSAPs in the state, so we definitely have a ways to go, but we are learning a ton and doing a lot of that hard process and mindset changing work right now by having these pilots in urban, suburban, and rural areas, and working with sites and PSAPs that are small, medium, and large. So we're really understanding, how do our protocols need to change across the spectrum. So far, up until June 5th, we had 127 calls transferred. Most calls were able to be addressed by 988. Some were sent to mobile crisis, and some were sent back to 911. And this shows us the system's working, right? We're getting to 988, and 988 is able to send to mobile crisis and to send back to 911 if needed. Next slide, please. So what are we learning so far? Overall, the pilots are doing what we've designed them to do, which is starting to implement and really serve our residents and figuring out those process changes, figuring out what's working and what's not. So once we start really aggressively moving closer to statewide starting this fall, we have a better understanding of what our process sticking points are, what's working, what isn't in different types of settings. We are getting that alternate response. We're collecting really great data and meeting with our PSAPs every week, and are excited to be able to share more about that soon because we just completed our first data collection period. So we're in the analysis phase now. Next slide, please. And then finally, wanted to share a brief update on how Illinois is responding to the federal government sunsetting the LGBTQIA plus youth line through 988, the sub-network. We are trying to affirm really clearly that we are committed to providing free, confidential, culturally competent care 24/7. Oop, this says 366 accidentally, even more than every day a year. That's how committed we are. And in particular to youth who we know are at very high risk of self-harm and suicidal ideation. So we have a month to prepare, and these are some of the things that we've been doing. We started with data collection. We've been working with Vibrance. Oh, leap year, good points. We've been working with Vibrant to understand what is the call volume and trying to get any information we can about why individuals might click free or text pride. We did one-on-ones with all of our providers to understand how they do or don't feel prepared. We've heard a lot of need for additional resources, and just knowing where to specifically send folks that'll be safe for LGBTQ youth. So now we're working to gather that, and also are talking about how we're going to get additional training for this specific population. We've been communicating through our 988 advertising with images like some of these that are specifically meant to signal to LGBTQ individuals, especially youth. So we're continuing to push that out. And then uplifting all sorts of existing resources we have for individuals, which we have from youth all the way through elders, all sorts of resources that I'd be happy to drop in the chat. So thank you so much for letting us share a bit about what's happening in Illinois.
Allie, fantastic. And the fact that it's going statewide in the fall and that your PSAPs meet weekly, that's incredible.
Just 19 of them, but they are an incredible 19.
Yeah, no, it's really good. It's great collaboration there. So thank you so much for sharing this. And we're
Yeah.
thrilled for Illinois and the movement here. So thank
Thanks
you.
so much.
And so what this map is, these are states that have highlighted their efforts during a feature presentation. And the ones that don't have a little picture in there, we hope come along. So South Dakota is next week, but please take a look, and we would love to highlight something from your state during a feature presentation. We're now going to move to Menta. And let's go to Victor Arias. Yeah? Okay,
Yes, thank you so
Victor.
much, Megan.
Thank you.
Great.
Go
I'm actually gonna quickly introduce my best friend and co-founder, Dan McSwain, out of Washington, D.C. I hope he's on as well. Just want to make sure.
Hey, I'm here.
All right. Dan, you want to kick us
Yeah,
off real quick?
sure. Hey, everybody. Thank you so much for what you're doing, and thank you for inviting us in to be a part of this with you this week. Thank you especially to David Covington and his team. David actually attended one of our events recently in Phoenix, and that kicked off this invitation here with this incredible group. Mente is a 2-year-old organization focused on engaging young, diverse audiences around mental health and healing. And Victor's going to talk a little bit more about how we do that, but I just wanted to highlight this recent report from BetterHelp that came out in May of this year that showed that for a really large share of Gen Z audiences, that especially the ones that spend the most time online, they are likely to prefer group therapy over other formats, and cost barriers are, as this group knows, a huge barrier. I think there's a sort of like misconception that young audiences are perhaps less interested in multimodal healing experiences, but as Victor will tell you, that's been quite the opposite of what we've learned in building and running Mente. I'm based in Washington, D.C. Victor and the team are based in LA, and I will throw it to Victor.
Thanks, Dan. Hi, everybody. I'm Victor Arias. So just a quick backstory on me and Dan. Dan and I were our childhood best friends. We met when we were 12 in Dallas, Texas. And in fact, our moms met at church. They still go to church together every Sunday. It's a lifelong friendship. Dan and I are still connected through our friendship and through family. Just to share, I was going through a mental health crisis right during and a little bit after the pandemic, and Dan was one of the only people that I could reach out to talk about some of the things I was going through and to learn more about kind of the process of finding help. And along that journey, we both decided to dedicate more time to each other and to learning more about the space. So, in full transparency, I don't come from this world, and neither does Dan. My background is in public relations and marketing. I actually kind of cut my teeth at Edelman in New York City for many years, where I kind of learned how to engage with hard to reach audiences for big brands. And Dan, on the other side, is in Washington, D.C., and has a political background. He actually worked on the Obama campaign in 2008 and was the president's blogger after that. He also has a background in startups and in tech and spent some time in the Bay Area as well. And so in our year and a half journey, we noticed that we kept seeing more stats beyond these that say things like young Americans are feeling extremely lonely. They also turn to social media as kind of a double-edged sword. In one sense, you get a lot of information that you may not have had access to before, especially for underrepresented communities. And then on the other side, it still causes you to feel more lonely. It causes you to doom scroll. It causes you to feel bad about yourself because you're comparing yourself to other people or situations. And so, on top of that, many folks, many young Americans feel like therapy, clinical therapy, is just not accessible, or there are cultural stigmas to even approaching that. I know for myself, I had to kind of work through a lot of cultural barriers coming from a Mexican American household before I could even start working on the issues that I needed to work on for myself. And so I truly believe that is true. And so what we came up with is a platform that we know resonates with young people and especially with young men, and that's comedy. Stand-up comedy is something that is very accessible. You can put it on anywhere. It's pretty cheap. You could get into a comedy show for 5, 10, 15 bucks. But what we do that's different is we have a program where the first half of our entertainment is truly that. It's stand-up comedy. We're in a room together as a community. We're laughing. Our barriers are coming down. And then the second half, we have our creative director from Mente, who is a stand-up comedian and also a men's mental health advocate and Latino himself, do almost like a crowdsourcing of issues. We have different names for these depending on where we show up and how we do it. But really, it's an opportunity for the audience to say, like, hey, this is kind of bothering me, or hey, has anyone else dealt with an issue like this? Sometimes it's pretty heavy, sometimes it's funny, sometimes it's a little bit of both. But the result is at the end of these stand-up comedy shows that we kind of dub as like almost like free group therapy, right? People are connecting with each other. They're sharing their Instagram handles. They're sharing their phone numbers, and as a result, we've been able to build a community online of about 21,000 folks across Instagram and TikTok. Our Instagram is at mente.world on Instagram and TikTok. And there's a lot of examples of how this comes to life, but we're trying to take a unique, more approachable way of thinking about building community around mental health, having these discussions, and offering resources to the people that need it most.
And Victor, that's incredible. Building community is so important. And connecting is so healing. So thank you so much to you both.
Thank you for having us.
Mm-hmm. And let's go to Stephanie Hepburn and on Crisis Talk.
Thanks, Megan. So I'd like to bring on Dr. Zeller again. Hi, so nice to see you. So in our discussion, we chatted about how you were led to developing Empath through your experience in Alameda County. People can go to the article to look up that history. But during the presentation, I thought you mentioned gentle line of sight. What does that mean?
I think that means when this is an environment where it's not like you have a sitter or a security guard, within 2 feet of you, like is in the typical ER. But we've designed empath units where they're open spaces where you're free to move about, but the staff can see where everybody is, so there's not a concern that they need to be highly ligature-free environment or need to be arm's length away from people, but that we're going to just give people the opportunity to relax and feel safe. And at the same time, it's designed in such a way that organizations like the Joint Commission and CMS and everything aren't saying, wait, you can't do that. No, they actually endorse the design, and it's nice compared to what's traditionally been a much more coercive and confining environment for behavioral health patients.
I think I have time for one more question. That's it, which is, I was thinking about young people during this discussion. I'm assuming that young people are also able to utilize Empath. Does that look at all different?
Yeah, so one of the most exciting things about Empath is the creation of a lot of pediatric adolescent empath units around the country in the last few years. It's one of the hottest things going on in Empath, and some of them are actually where they even have 2 empath units side by side, an adult and pediatric, where they have a movable wall depending on which side has more patients, and they can move them side to side. But in the pediatric or adolescent side is going to be a lot more youth friendly and be more focused on kind of bringing some relaxation and fun and recreational things into it, having a good access to family meetings in a way that people can kind of get to the bottom of what's going on and not really just this is not just an adult who needs some time to heal, but maybe we're going to get to the bottom of what's going on, and maybe hospitalization isn't needed, but let's really start creating a situation where we're changing that emergency patient into an outpatient and getting them connected to the right resources.
Well, thank you so much for staying on with me. I appreciate it. Thank you.
Absolutely.
Thank you, Stephanie. Thank you, Dr. Zeller. And so next week is episode of 226 with South Dakota, Creative Solutions to Increase Access and Care. And then the week after that is the debate on coordinating follow-up care and crisis services requires high-tech software solutions. So we'll check all that out and learn a lot. Thank you, everybody, for watching today, and we'll see you next time.